Right. In this session, we are going to start with the test based on the metabolic effects of thyroid hormones. If you remember from your endocrinology classes, thyroid hormones has a metabolic function also. Okay. So it is responsible for maintenance of BMR, basal metabolic rate in the person's body. So we can assess this effect of thyroid hormones and see how the thyroids are functioning based on BMR levels. So number one is testing for basal metabolic rate, serum cholesterol levels. Again, it is related to metabolism. Serum creatine levels, serum uric acid levels, and serum creatine kinase levels. So all this gives us an idea about the metabolic effects of thyroid hormones, and also hypercalcemia, which is indirectly related to thyroid hormones. We will start with basal metabolic rate. It is very useful in diagnosis and very valuable in assessment of severity of thyroid diseases and prognosis. Okay, so its application within thyroid function test, application of BMR within the thyroid function test is to diagnose and to assess severity and prognosis. So basically, all three aspects of any disease progression we can see: diagnosis, prognosis, and severity. So for this to be anywhere near accurate, at least two estimations should be done. Two estimations of basal metabolic rate should be done consecutively, okay, back to back after proper sedation is given to the patient, so that he is very physically and mentally rested. As much as physical and mental rest is increased, it gives more accuracy towards the assessment of BMR. So next point you have to keep in mind is this is not done once, it is done back to back at least twice. Okay, and the patient should be in a state of complete physical and mental rest. So normal BMR indicates should be between 55 to 20%. In euthyroid states, a plus or minus 10% of normal is seen. Okay, we can go up to 1 second. Thyroid states, plus or minus 10% of normal BMR can be expected. So in hyperthyroidism, means more thyroid is there, it's directly related to the metabolic status. More thyroid hormones, the metabolic rate will also increase. So around an additional 50 to 75% of increased BMR can be seen. And in hypothyroidism, it is reducing. Okay, it reduces. Plus around minus 20% is suggestive, usually minus 30 to 60% seen in hypothyroid state. So what do we know? What do we know from this? So BMR is very important. It is directly related to the thyroid hormones. Okay. So thyroid hormones are used for checking the hypothyroid or the thyroid's functional status. Is it euthyroid, hyper or hypothyroid condition? Okay. So now if BMR is higher, then it indicates hyperthyroidism. If it is lower than normal, it indicates hypothyroidism, and that is how we use BMR for assessment of thyroid function. Next is serum cholesterol levels. Now, from this point onwards, the relationship between thyroid and other these markers that we are going to discuss will be indirectly related. So, will not be directly related. Okay. So, serum cholesterol levels are useful in assessment of hypothyroidism, where it is usually high. A patient with hyperthyroidism always shows a high serum cholesterol levels. Serum cholesterol levels does not play much role, and it does not have much value in assessment of hyperthyroidism, though it is usually low. Okay, because when you see the normal range of serum cholesterol, it starts from 0 up to 150 milligram per BL. So because of this, we cannot go down. Okay, anything less than 0 is not possible. There should be some amount of cholesterol in patient's body. However, patients who are hyperthyroid, having hyperthyroid issues, the cholesterol level is usually on the lower side. In hypothyroidism, the reason why it is high. So in hypothyroidism, the synthesis of cholesterol is impaired, but catabolism is reduced. Okay, production will not be there. However, because of this, there will not be breakdown of any cholesterol leading to high cholesterol level. But you have to keep in mind that this serum cholesterol levels is indirectly related to thyroid function because one of the important factors where cholesterol gets influenced within our body is our diet. Okay, so our diet plays a very important role in maintenance of serum cholesterol levels within these ranges. So it's very important that we remember the role of cholesterol and its involvement in thyroid function is indirect. Same with creatine level. So we take a study from here. Okay. So we use a study from the he advocated the estimation of serum creatine level for diagnosis of hyperthyroidism. Now, as we see, cholesterol does not play a very important role in identification or diagnosis of hyperthyroidism. So we use serum creatine levels. We consider a serum level of creatine greater than 0.6 milligram per DL is diagnostic. Okay, that's diagnostic importance. And he also said a normal serum creatine level and normal BMR in a patient excludes thyroid dysfunction. Okay, according to him, he said if a patient is having normal serum creatine levels and a normal BMR, that patient should be excluded from considering to have any thyroid dysfunction. He has a normal thyroid function. When the symptoms of thyroid disorders are present, a raised serum creatinine is highly significant even though BMR is normal. So according to him, serum creatine is far more important than BMR in diagnosis. But we have seen that BMR plays a very important role in both ways. Okay, in also hypothyroidism and also in hyperthyroidism. Next is uric acid. It is found in mixed males. Levels are increased and postmenopausal women. The value ranges from 6.5 to 11 milligram per day. So again, very low amount of relation here between serum uh, uric acid levels and thyroid condition. Creatine kinase, how is it related? So serum creatine kinase levels are often raised in hypothyroidism, but the estimation does not help in diagnosis because CK is far more important in other areas other than thyroid. It's used for estimation of muscle disorders, including cardiac and skeletal muscle disorders. It's used in checking for diseases in liver. Okay, so even with increased CK values, it is linked to hypothyroidism, but we cannot base our diagnosis of hypothyroidism on zero CK values. It also can be seen raised in thyrotoxic myopathy and hypercalcemia. It is very rare and its high levels of calcium can be found only in severe thyrotoxicosis. This is because of an increased turnover of bone. Okay, so what is this turnover of bone? The bone starts to lose calcium. Okay, as increase in thyroid hormones are seen. So this is linked, and increase bone turnover is related to direct action of thyroid hormones. Because of this, more and more calcium will be released into the blood serum, resulting in hypercalcemia. So then let us scan some thyroids and we'll see. So CT scans provides visualization of distribution of radioactive iodine in the gland. It also permits characterization of its anatomical features. So this is observation, okay, to check. So we are not doing this. We are not going to look at these reports also. So it's completely out of our domain. But you have to know that any radioactive uptake is there. Test is done. Immediately they are going to check for thyroid scanning to see the distribution of radioactive iodine throughout the anatomical features. And finally, immunological test for thyroid functions. There are many autoimmune diseases where what is autoimmunity? It is the immune system considers the cells as an foreign antigen. Okay, so because of that, to eliminate these antigens or these cells, it starts to produce antibodies. So this is called as autoantibodies. So assessment of autoantibodies helps us in detection and determination of many autoimmune diseases of thyroid. We can expect some anti-thyroid autoantibodies in variety of thyroid diseases, different autoimmune disorders, and also in certain malignancies. Some tumor cases also we can expect. So these autoantibodies are directed against several thyroid components and thyroid hormone antigens. Okay. So the focus of these antibodies is against the components. It can be cells, it can be proteins, it can be hormones, etc. Thyroglobin, thyroid microsomal antigen, ASH receptor. So these are the antibodies we can see. Okay, the names of antibodies. And thyroglobulin antibody, anti-thyroid microsomal antibody, ASH receptor antibody, non-thyroglobulin colloidal antigen, and also producer antibody, thyroid stimulating hormone antibodies, etc. So this gives an example of how widespread the autoimmune diseases can be within the thyroid glands. Not just to the hormones and proteins, it can also get produce an antibody against the receptors present on thyroid glands, which will attract TSH. Okay. So how do we do this? So there are many immunological tests that are available, but the basis of this is the interaction between antigen and antibody. Okay. Any immunological test we can see, ranging from ELISA, chemiluminescence, FIA, RIA, etc. You can do many number of. The basis of these tests are antigen antibody reaction. Okay.